Good afternoon and good morning to everyone, and thank you for joining us for Day 2 of the 2021 Healthcare Project Delivery Conference. We have over 550 people registered and even had a few new registrations yesterday and even this morning. We have another fantastic day of programming, including an opening plenary with some of our nation's children's hospitals and an afternoon fireside chat with Dr. Peter Antal, the Chief Medical Officer from Amwell Health. Dr. Antal will be discussing the growth of telemedicine with Lisa Freely from E2 Strategies. I truly hope that everyone enjoyed the program and the networking yesterday. Our team has been very pleased with how engaged you are and hope this engagement and curiosity continues today and tomorrow. Please take some time to visit the networking hall throughout the conference and at the end of the day's programming to connect and meet some new people. Additionally, don't forget to visit the expo hall and learn about our sponsors and exhibitors and to hunt for the 3 new hospitals hidden today. Reach out to the help desk and let them know you found them and you'll be entered for an Amazon gift card. Lastly, I would like to again thank all of our program partners and sponsors. This event would not be possible without their involvement. I'd like to first thank our Diamond sponsor, Plenary. I'd also like to thank our gold sponsor, C-Power Energy Management, and also to thank you to our silver sponsor, Johnson Controls, and to our exhibitors, Better GIS, Forbo Flooring Systems, HHI Corporation, Embar C Construction, and Next Era Energy. Finally, to our program partner, AIAI, the Association for the Improvement of American Infrastructure. I would now like to introduce Melinda Lin. Melinda who will be our moderator for this morning's plenary. Melinda has nearly 20 years of experience representing clients and planners. She has worked with some of the leading design firms and healthcare systems in the country, and her project experience includes hospitals, medical campuses, and medical office buildings, with a specialty in medical planning and operations. She has a passion for healthcare planning and the improvement of facilities to provide positive patient and caregiver experiences, especially for our nation's children. Melinda, thank you for joining us, and over to you.
Good morning, everyone. Thank you for joining us today. I'm Melinda Lin, as I've been nicely introduced as, and I am the moderator for this session. And this session is about how are our children's hospitals faring in this post-COVID world. I'd like to take this time and introduce our panelists and have them introduce themselves as well. Jennifer.
Thank you, Melinda. I'm Jennifer Mishkin, and I am the Director of Facility Planning at Nemours in the Delaware Valley. And I've been there for about 6 months.
Hi, good afternoon. It's great to, or morning, wherever you may be. It's great to be with you all today. I'm Kathy Gorman, and I'm the Chief Operating Officer at Children's National Hospital in the heart of Washington, D.C.
And we lost our third panelist. We are trying to locate him. It is Serge Avazin from Children's Hospital of Orange County of California, and he will hopefully be with us momentarily. So I'm just going to go ahead and get started with our session so then everyone out there can be entertained with our conversation. So we've spent the last year in various forms of lockdown because of COVID and where we've lived in our different statuses of opening up our country. We hear about how this is affecting our daily lives as adults, but we barely hear what's happening to our children and how it's affecting their lives on a daily basis. Speaking from all of our general perspective geographical areas, East and West Coast, what are the things that you're seeing as a cultural shift and social shift in your services of care and services in the facilities in which house them?
You know, Jennifer, let me start by saying that it is somewhat of a myth out there that children have not been impacted by COVID, because they certainly have. And boy, do we appreciate your passion for those of us who are all kids all the time. That's all we do. And particularly at Children's National in Washington, D.C., we have experienced a high number of children in our region who had tested positive or have needed to receive services at Children's National. So let's start there, that COVID is very much present and in our community for where our children are. We've identified over this past year new diagnoses that we never had before. And by way of background, I'm a nurse, very much involved in the clinical aspects in partnership with our chief medical officer as well. But new diagnoses such as multi-system inflammatory disease, which is impacting kids at a high rate. When we start to look at what this overall shift has meant for kids, I think there's several things. One, our kind of D-Day, so to speak, is March 15th, when we had our first patient and our first employee who tested positive. And as a result of that, we had to quickly shift our care models. So our care models have shifted towards a model of telemedicine that is more accessible to our children. We had to shift and think about how we pull patients into our organization and how we care for them and how we manage them throughout their stay if they're an inpatient. We shifted our workforce very quickly, our administrative workforce, to teleworking, which is a huge cultural shift. When as healthcare organizations, we're so used to working as teams, as in other industries, but how do we create that connectivity? And from a clinical impact, I talked about some of the acute conditions, but we're also seeing the impact of COVID on the mental health of children. And so I think all of those things combined are huge. But what we really have noticed significantly from a hospital facility standpoint has been some of the shift in care and the reduction of patients who need to utilize our facilities from an emergency department perspective. Or as they've shifted to telemedicine, the reduction or the need and the looking at the room utilization in our ambulatory spaces is very different. So there's a lot to unpack in that question, but I'll just kind of, start there and turn it over to Jennifer to add as well.
Thank you, Kathy. We have very similar experiences in terms of the shift of telecommuting for our administrative staff. We still are at a point where those folks are working remotely as best they can, and people are on site as needed. So obviously our clinical support staff have been there throughout the pandemic. We actually partner very closely with the state of Delaware, and we're set up to be potentially an adult overflow site for non-COVID patients. We didn't have to utilize that, but that I think is another impact or potential planning and replanning and sort of the moving target of this whole experience. The other thing that we've noticed is obviously the reduction in sort of the typical cases, the flu season, typical basic injuries and things like that. All of those things are much reduced, and we are seeing, as Kathy indicated, the more acute cases, the cases that are coming in and people haven't been to their primary care visits as they should be. And so there's really also been a focus on that, which aligns with our overall focus of really focusing on healthy kids and trying to have the healthiest generation of kids. And so there was a very strong effort around infant immunization, setting up tents to make sure that those were still happening. And then the same approach with the flu vaccinations in the fall. And so we're very proud that we got those flu vaccinations to a slightly higher percentage than they were in 2019. So that was really a targeted effort to make sure that people were still having those preventative immunizations that hopefully will help with, illnesses and things like that. I don't know if Serge wants to join in at this point for the West Coast.
I apologize. I had some technical difficulties, so I missed a good chunk of the question. But from what I gathered, sounds like we're talking about some things that are different than what we're normally used to from the pandemic. Yeah. Jennifer, a lot of what you said is a lot of what's true on the West Side as well. Our censuses are pretty low right now. We don't see as many ED visits as we normally have seen in the past. the flu numbers are as well down, and the entire landscape has somewhat just been different. And I'm not sure how it is with all of you, but we keep saying, "Oh, things will normalize and get back to what we've seen them before, and it'll get there." But it's been about a year, and so some of those stats are still trending the same way they've been trending over the last few years.
Serge, a question for you. Since you're in California like me, and you've been in one of the hot spots for COVID testing and the continuous rise of not being able to flatten, or we flattened and then we would still keep going up. Are you finding that is having a really big impact to the pediatric care that you're seeing? Because we can't seem to flatten in California. We're getting there now, but we haven't had that opportunity in the past.
On the ped side, it's a bit different than the adult side. On the ped side, we've managed it fairly well.
Good.
What we've been doing on the ped side is trying to support the adult side with their overflows and so on and so forth. And typically on pediatric side, we don't see any adults or even prepare for adults, but this was the first time where we said, well, how can we bring adults in here? Fortunately, it never got to that point. So though the numbers did go up, I think a lot of the institutions did well in trying to manage their flows and their throughput and all of that. So I think it was just a lot of preparation and being able to handle what may come down. And all of the other protocols that have been put into place with hand hygiene or masking and all of that is the best we could really do, and educating a lot of our staff and associates as well as patients when they come in. What they see on TV versus what they hear from a practitioner could be two different things.
Jennifer, Kathleen, do you want to add to any of that?
I would say that our experience in Washington has been probably one of the kind of more hot spots as well in the country. We've cared for almost 2,200 COVID positive patients within our health system, and probably, and I guess maybe well over 100 of the MIS-C, the multi-system inflammatory children. We have conducted right now, we just hit a number of over 50,000 COVID tests that we've conducted, and so now we're into the vaccine stage as well. But I think in terms of the impact, I think, I don't think things are going to return to normal. I think that's pretty clear in the pediatric world. Eventually, we'll probably, as children come back to school, we'll probably start to see that spread of infection that we saw before for the enteroviruses or the RSV or the common cold or the flu. But we don't believe that that's probably going to be in the near term. So we are anticipating that we're going to continue to see this higher acuity patient population. Our case mix index is up by 20%, and our length of stay is up by about 22%. So even though our volume of patients, the number of patients that are accessing our services is down, that they're down in the respiratory illnesses and they're down in the observation cases. So patients are coming in sicker and they're staying longer. They're requiring more services in pharmacy, in laboratory, in radiology. And so those services are really, really heavily needed. And in the emergency room as well, many organizations across the country in PEDS are seeing a 30 to 40% reduction in their emergency room visits. And but what we've seen is, even though we've seen that reduction, we've seen an increase in that acuity and the need for those facilities and those services to support. Interestingly enough, from a facility standpoint, I know we'll probably get into this at some point, is the planning. We had a major renovation plan for our emergency department, several $1 million renovation. We actually put that on hold right now until we determine what's going to happen with this population, recognizing we need to do some refreshes, but in terms of that bigger picture, looking at, as we look out over the horizon and into the future, what does that mean for kids? And I keep coming back. I think we learn something new every day about how COVID impacts us. We just really don't even know the long-term effects of what COVID is going to do. And I think that's where research and innovation and making sure we're partnering with our academic partners. We just received a large grant, or working with NIH around looking at the long-term effects of kids and COVID on kids.
Jennifer, do you want to add anything in what you're doing?
Just an incidental note about the ear, nose, and throat doctor. There was a presentation that was talking about that, and because we have primary care in Pennsylvania, New Jersey, and Delaware, they can actually see a difference in those numbers based on which areas had schools open and schools closed and virtual. And so that was really seemed like a direct correlation in terms of that impact. And so I think that is something that, as schools here start to reopen more broadly, that will start to shift again. And I think, to Kathy's point, certainly our facilities-based projects, we are absolutely reevaluating things that were previously approved. Does this still make sense? We have that both from the care standpoint, and then, as I mentioned, the telecommuting with the associates. We've canceled some projects because we don't need to do them, because those people aren't here. So why would we renovate a space for them? And then it's the determination of, well, what's the best use of that space now with what we know. The same evaluation with conference rooms and things like that, and how can we utilize them for other purposes so that we're really making the best use of our space and supporting the associates who are there and working, and kind of finding that balance in something that we can't look back and go, oh, well, this is the typical ratio for these things. It's as Kathy said, it's different each day, and it's evolving.
So then, have you been able to take this opportunity not only to shift your capital projects, but also in taking this so-called quiet time, very, very, I hate using that word, but it's not as hectic as usual, to be able to think about reorganization of the clinics, co-locating, specializing services more together, or becoming more centralized or decentralized?
So I can start us off on that one. We actually are in the process of launching an enterprise-wide master plan that was planned anyway, but we are certainly taking this opportunity to reevaluate the services to align with a new strategic vision from the organization. And so we have taken the opportunity both to evaluate projects that, as I said, were previously approved, but also to look at how do we want to approach this, and what's the best process to have something that not only is relevant now, but that will be more flexible moving forward than a typical master plan approach might be.
And I would add, along with that, we're in the middle of really a 5 or 6 year master facility plan. We launched it about 4 years ago. Or 3 years ago. And so over this past year, regardless of that, our CEO and our board made very intentional decisions to continue with our facility planning where it made sense. So over this past year, we opened up a 25,000 square foot outpatient mental health facility. We opened up a primary care center that's a smaller one, around 20,000 square feet. We opened up an ambulatory pavilion in Prince George's County to combine 2 regional outpatient centers that was over 60,000 square foot. We opened that up last July. We are just very proud, and yesterday you heard, if you were listening, my CEO, Dr. Kurt Newman, speak about our Research and Innovation Campus, which is a 160,000 square foot research innovation campus that we move forward with, that has a rare disease clinic in it. We are partnering with J Labs and Virginia Tech on that partnership, and J Labs is moving in, or they have moved in. We are opening up a primary care center in this specific area, which is called Ward 4 in the District of Columbia. And we have a 300 in-person theater that we hope will be able to be in person really soon once everyone gets vaccinated. We've also expanded remote locations deep into Virginia and up into Montgomery County, which is north of the DC area. We also, this one was a little bit interesting, but we opened up we leased a new administrative space that we said we needed to just move forward with. It's 189,000 square feet, and they got a lot of people telecommuting. Right now it's a little bit empty, so we're working on how do we start to bring people back in a very safe way in that space. But and then with that, that is also, we'll be opening up a new sports medicine clinic later, actually in March next week, in that space. So very excited about the expansion. But to that end, it's all been intentional, and we look to see, were there off-ramps that we could actually move off of, and creating those off-ramps. And as I mentioned, as we look at some of the facility changes at the hospital and the hospital location, we're looking at making some changes there, but in particular around the emergency department and this spend that we had intentionally there. But we're also spending time to think about, our high acuity patients and how do we create new strategies and thinking about those high acuity patients to move forward in the service lines of cardiac and surgery and other lines.
Serge, what are you seeing out there?
Yeah, from our side, it's interesting. I think a lot of institutions are probably somewhat in similar boat. We are going through an extensive facilities enterprise master plan as well. And we've built this vision, we've built this plan of how we wanted to move forward and what we wanted to do and what all those programs were. And Melinda, you had asked this question about decentralization and centralization and some downtime, or, we haven't really felt any downtime. I wish we did, but it's actually been a lot busier. And part of it has been going back to the drawing board and re-strategizing certain things, revisiting our numbers. Do these volumes that we were looking at a year ago make sense today? And how will they look 3 years from now or 4 years from now? And seeing the shift in how care is being taken place or what the population is doing has also changed our thinking around, well, I think Jennifer and both Kathleen said, is this a service we still want to put forward? Or do we want to expand this from what it was before? And on top of that, there's another huge question mark, which is, well, since our volumes have changed and they don't look the same or they're different, well, our finances are impacted by that. So how do our finances now play into what we originally thought about for master plan versus now where we want to go with master plan? And part of that is, well, back to some of those decision gates or off-ramps and on-ramps, also in correlation with finances. Well, how much do we want to cash flow within this year or next year or the year after that? And if we cash flow that, well, which programs do we really want to put forward that we think has an immediate need in the next 2-3 years? So there's a lot of, I think, complex, faceted ideas that have to get approached. And I have felt that it's become a lot more centralized in the thinking and decision making and the work being done than decentralized. And I know that some other colleagues on this west side, other institutions, are pretty much going through similar exercises that we're going through.
Thank you. So since some schools are in session, some schools are not. We've got a mixed bag here. Are you seeing things that, I guess, caseloads that are different because you don't have that child advocate, a teacher, a counselor, a school nurse to be able to casually administer their knowledge on a child and do a tap on the shoulder and say, hey, maybe we need to talk to you or talk to the parents? Are you seeing a drop in those kinds of advocacy for kids and teens? Or is it still kind of same business protocol as you've had in the past?
I can certainly jump in and take that one. So from a school advocacy perspective, we have been very active in this space. And in particular, we have the school nurses in the District of Columbia that report into Children's National. We have a relationship with our DC Health over this. So we have spent a lot of time utilizing those school nurses in various different ways to help to support the kids. As it relates to getting kids back to school, just last week we finished vaccinating around 3,400 District of Columbia public school teachers and charter school teachers with COVID-19 vaccine. So we were able to do that to get them back to school. What are we seeing in mental health? We are seeing an increase in mental health visits. In particular, our ambulatory visits are up, but also we're starting to see an increase now in those patients needing inpatient care. So we have, as the schools reopen and the kids are going back to school, it's hard for them to re-socialize and determine, how do they fit in? What are their cliques? Who is in their clique? Who's not in their clique? And how do they make sense of all this? I mean, I think there's going to be a huge normalization period. And whatever normal isn't normal anymore, right? But whatever that is for our kids, we're working on helping them. So we've built into our primary care model, and I'm sure Jennifer and Serge have done the same. We've built in mental health services into our primary care model. So we have a psychologist and psychiatrist working alongside with our primary care physicians. We've had that model for a while, but we're looking at accelerating that. But during this time, our commitment to the mental health, to children with mental health issues or challenges, behavioral health challenges in our community has never been stronger because, like I said, we opened up almost a 25,000 square foot facility just for this issue and for kids. The challenges we're starting to see, we see a lot of those visits on telemedicine. And I think it's a good thing. There's a beauty and the curse, so to speak. It's a good thing. At the same time, kids are in school all day. So do they really want to be online with their therapist as they're managing through whatever issues? But I think in terms of getting kids back to school, we have to do that. We have to do that for their health and the health of our future.
Yeah, I would agree with that. We are also building a lot more telehealth and mental health around some of our other services, whether it's primary care or anything else. We're trying to see how we could integrate some of those things, and we are seeing an increase in mental health needs. And I know personally, just by hearing how much this has affected children and teens. And it can get pretty severe. I don't know if we don't realize it or see it, but there's a huge impact to these children. And mental health services is one thing, but bringing them back to that life that they probably want to be back to is an important part of their development and their growth and the nature of their mental health.
Jennifer, do you want to add anything?
So I think that the one key piece that we have at Nemours as part of our VBSO program is they actually have launched a social determinants of health screener that is utilized at primary care. And what they're seeing is that the issues of concern throughout this pandemic have shifted. And so then trying to be able to support not just the medical needs, but also getting people in touch with organizations who can support those other needs in terms of food security and housing and things like that, because there is so much more going on. And as Kathy said, the kids are absolutely feeling all of this and the stress that goes along with it. And so I think that that's one of the signature pieces that we've launched in the last year.
Okay, one question I have for you as coming from an architectural standpoint is what are you doing in your facilities to adapt to the daily operational work and the COVID cleaning, disinfecting? Gleam is clean. If it's not white and shiny, it doesn't appear that it can be clean and sterile. What are your thoughts on that?
I can jump in on this one first. We're also getting prepared for Joint Commission in Delaware Valley. And so we had been doing a lot of inspections of furniture and surfaces and all of that goes along with it. And so where we used to say, okay, a Krypton fabric that is cleanable is good. And now everybody wants it to actually be wipeable with a cavi wipe. And so we've done a lot of reupholstery of furniture to get it to a point that it can be wiped down between patients being there, even in the waiting rooms. We have things segmented off. We have chairs that are strapped so they can't be used, or turned towards the wall so they can't be used, to really control how close together people are sitting in waiting rooms, which I'm sure everybody has done. We've tried to minimize how many of the stay 6 feet away many floor decals we have, but we certainly have those in certain locations, in elevators. And then it's really just working with the EVS staff on what those cleaning protocols are. And really the distinction that we've come across is that cleaning is different than disinfecting, and that you have to have both of those to have the environment look clean and also be disinfected, but the disinfectant does not actually do the cleaning. And so that has been a distinction, and really working with the manufacturers on what can we use on these products so that they're not deteriorating because of all of the excessive cleaning that's going on. So those have been some big factors that we've been working with.
Yeah, similar to Jennifer, this was really one of our early strategies as we started to recover. So immediately when COVID hit, we all saw a significant drop in our volumes. We were pretty much mandated by not only not federal, but state requirements to reduce elective surgeries. And for what that means for kids, there really aren't elective surgeries, but it was still, we needed to reduce those. So as we started to recover and started to recognizing that we needed to gain the confidence or regain the confidence of our community in our facility, the cleaning and the experience has been critical. And when you have an aging facility, such as Children's National is we have some of our building is 40 years old, some of it is 12 or 15 years old. But when you have that aging facility, that becomes very difficult to say, what does this look like? How do we spruce this up? So we have spent a lot of time in this area, in this space. Most notably, and it's very similar to Jennifer, so I won't repeat, same things, the cleaning supplies, what's deteriorating, the surfaces, etc., all looking at all that. Most notably, though, just this week, we have several little projects going on, and our head of construction noted to me that our regulators through the Department of Health in the city are now starting to put in place COVID regulations. So we had a space that should have been approved, and they said, no, you need to take this desk out because it's not 6 feet apart. And we said, okay, are these new regulations that are coming into place, which is really going to impact our facility design and how we function in the future? So we quickly adjusted. I have a few questions for the city on, are these new regulations? But it's a new, interesting dynamic and a paradigm shift if that's going to happen.
Serge, what about you?
Yeah, a lot of what Kathy and Jennifer are saying. We're taking a lot of different type of precautions from a cleaning standpoint and disinfection standpoint. There's just so much you can do and so much wear and tear. We're also doing a lot of pre-screening and COVID screening of all the contractors and folks that come in daily, regularly, and taking a lot of different precautions. In California, we're very heavily regulated with our space designs. We have OSHPD here that reviews and scrutinizes all of our plans on top of everything else. And so what Kathy just said kind of scares me a little bit because that would be a huge setback on a lot of the planning and strategies around how you try to be efficient with space, right? Because we're always thinking about how can I most maximize the space? How can I be efficient? Trying to fit 5 people into one place sometimes, I think that's no longer a consideration. Well, and now if they're going to make that as part of the regulation and review or a requirement, then completely forget about it. And so that might cause us to go back and rethink. So far, fortunately, California hasn't experienced that, and I hope we don't experience that, because I do believe that even though we're going through this situation, I don't believe that we should allow this situation to dictate our entire future, because we can conquer it, we can overcome it, and I don't think it's going to be the way that it's going to be for years to come. I think we should be able to develop and prepare flexibility in our spaces as a new way of thinking. How can we develop a space where if such a scenario takes place, we can immediately flex it and turn it into something that can accommodate? But I don't think we should design with the consideration of everything needs to be 6 feet apart. I feel like we would be shooting ourselves in the foot with design.
Agreed. Thank you. So we have about 8 minutes until there's a hard stop for 2 of our members today. Is there any last parting words of advice for our viewers out there? Any just thoughts that you want to leave with us to be able to share your experience and where you'd like to move forward in or to?
I think that, I can start with that. And it looks like there's a question as well from one of the viewers here, the participants, and it's talking about volume reductions. And do we think we're going to see that well into the future? I think we will continue to see volume reductions as it relates to the observation patients and those patients maybe perhaps with respiratory illness until respiratory conditions come back. Probably when people stop masking, and there's probably more of a spread, if we ever stop masking, more of a spread of respiratory illness. I do think for kids, we are going to continue to need high-end quaternary, tertiary facilities to support the high-end patient and the complex patient. That, I think, will never change, and we're going to continue to see that. If we look at some of the things that may be happening, there's some question on whether or not we're going to see a reduction in birth rate related to COVID, and that could have an impact on pediatrics into the future. So that is one area that I would say we should, keep our eye on. The changing care models is really important, and I think the changing care models are here to stay. In pediatrics in particular, our parents are millennials. And so the technology is incredibly important. They're much more facile than some of us, and they're able to utilize it. So advancing and enhancing technology and patient-facing technology is going to be an important strategy for the future. It will have an impact on facilities, I think, in terms of some of our ambulatory space and perhaps maybe a little bit on inpatient as well, and maybe emergency departments. So I think that technology piece is important. I also think that how we've shifted to teleworking and what teleworking looks like for the future for our administrative teams, I think it's here to stay. Again, it's a little bit of a crowd pleaser, and it's people like it who are working at home. I will say from a care perspective, and now I'm going to put on my hat as a patient care services EVP, it has impacted our teams and our team dynamics. So how we think about that piece in the future is really, really critically important. So I think telemedicine, teleworking, and shifting care models are really kind of the top 3 areas that I would say, we should be focused on.
So my thoughts around it is our metrics and data and statistics that we probably have always been used to capturing are probably just going to look a little bit differently. And maybe we have to start considering using other type of data variables to capture our performance or measuring how we're doing within an institution. So we all usually follow census, but well, how much can we rely on that now? And one of the other things that I think is important is a learning point for all of us, or at least on the West Side, is when we went through the whole COVID experience and we saw the significant drop in volume, I felt that a lot of institutions were sort of unprepared for how do we deal with these low volumes, because we were always used to a certain census and that level. And I think sort of the takeaway might be I think levels and volume will eventually get back to where it needs to get back to for institutions, but in the back of our minds should exist, how do we prepare for when volumes do drop again? How do we adapt to that situation so that we're not caught off guard, and be okay with that? Because when your volumes go down that low, your finances are severely impacted. And some institutions have had layoffs. They had a lot of flexing and people taking furloughs and not working, and that changes the morale of your staff. Wait a minute, you don't want me to come into work next week? I don't get it. And they've got their life to deal with as well. And I think another part of this is, I don't know if you all, Jennifer, Kathy, have seen this, but a fear of parents and children wanting to come into the institution because they're just afraid of coming out. And though we are doing our best to keep the hospital very clean and a disinfected environment, it's actually probably one of the cleanest places you can visit, to be honest, anywhere else in the world. And I don't think most families are educated or are informed that it's actually, don't stay home if you're sick. You should actually go to the ED if you're sick. Don't try to treat this on your own. And I think that reinforcement has to come back to families and patients so that they're not feeling afraid to come back into the ED or getting their treatment. And I think that will also help us. My only thoughts on this, and my closing thoughts on this, would be, don't allow this situation to instill so much fear in us where the way we start to plan inhibits us from being innovative. In fact, we should become way more innovative, and telehealth could be the way, and another means.
Yeah, I think we have similar focuses to those, but really the shift in care model is something that we are working on to really move from being a hospital-based healthcare provider to really having more of the focus be on health and wellness of children. And so that primary care focus, the vaccinations, things that keep kids healthy is really what we're trying to shift towards. And I think that this is an opportunity because of all of the disruption in healthcare and because of the shifts in volumes and how you can sort of leverage this as a time to pivot. I think will be really interesting to see over the next couple of years.
All right, thank you very much. We have 2 more minutes. Do we want to take any of the questions? I think we've answered most of them. We was talking about volumes. We talked about COVID-related cases. I think I'm going to give 2 minutes back to everybody's life unless there's any other closing remarks here.
No, let's get our kids vaccinated when we can.
All right. Thank you so very much for your time. Have a wonderful day. Thank you, audience. Everybody be well and be safe. Thank you.
Thank you, Melinda.
Thank you.